Regressive alterations of teeth. Regressive alterations are nothing but degenerative changes occurring in the teeth, either because of some physiological process, from some pathological process, or related to aging. So we'll see all the regressive alterations of teeth. The commonest change which we see in teeth related to age or as the person becomes older is the attrition of teeth. Attrition is basically the wearing of the incisal edges of the teeth. Usually the enamel surface is attrited. Sometimes it leads to exposure of dentin, and extreme cases you can even see the yellowish brown discoloration of dentin also. So what is attrition? Attrition is basically the physiologic wearing of tooth surfaces. Uh, it is physiologic process. It is not a pathologic process. It is occurring because of aging related process. Most commonly, teeth are treated because of heavy masticatory forces. So normally the maxillary and mandibular teeth, they come in contact during mastication process. So some amount of wear regularly occurs throughout an individual's life. If the forces are excessive, masticatory forces are excessive, or there is abnormal contact between the maxillary and mandibular teeth, it ultimately leads to attrition. So attrition is nothing but the wearing of tooth surfaces. Initially, you can see attrition in the form of just the cusp tip shows the wear, or it shows the flattening of the incisal edges. Then it progresses to severe loss of the enamel, loss of vertical dimension ultimately. It exposes the dentin, so yellowish discoloration, yellowish dentin can be seen from the external surface. So more commonly, males are affected because of the heavier masticatory load and because of the coarse nature of the diet, and a few of the habits like tobacco chewing and all, they all contribute to this attrition. And as you can see in the clinical picture, sometimes whole of the enamel surface is eroded and just the you can see visible dentin in the oral cavity. So all the surfaces, either the occlusal surfaces of the posterior teeth, incisal surfaces of anterior teeth, even the proximal surfaces show attrition. Attrition, it affects both the deciduous as well as the permanent dentition. In cases of deciduous dentition, attrition may not be visible because the deciduous teeth remain for a shorter time in oral cavity, right? Yeah, whenever there are developmental disorders like amelogenesis imperfecta and dentinogenesis imperfecta, in such cases, extremely treated teeth may be seen. In cases of permanent dentition also, few of the authors have proposed that regularly there will be some proximal attrition occurring in all the teeth. In all teeth present in oral cavity, regularly few of the proximal surfaces undergo attrition. So there is authors have proposed that as person advances in age, there is a narrowing of the dental arch because of this mesiodistal diameter loss because of the attrition. Here you can see a radiographic picture of the attrited teeth. In cases of deep bite with malocclusions also, whenever the lower incisor teeth are extremely extruded in the oral cavity, then severe deep bite can be seen. Here this is a case of deep bite only, and with severe attrition of the mandibular incisor teeth. So when you see the radiographic picture, enamel may not be visible, the teeth will be flat, you cannot make out any cuspal outlines as such. So, and mammalians are nothing but developmental globules seen on the enamel surface. They represent the depressions like that. So there will be loss of mammalians on the enamel surface. Complete enamel is treated here, right? And the pulp chamber and canal, they'll be decreased in size because of attrition. What happens, underlying cells are stimulated, osteoclasts are stimulated, osteoblasts are stimulated, they lead to this hypercementosis of the root surfaces. So that's about attrition. to treat the attrition. Attrition, it has been attributed to bruxism habit also, where the individual under some psychological tension, he indulges in this attrition habit. So based on the appropriate etiology or identified cause, treatment should be given accordingly. Sometimes the pulp chambers will be exposed, so endodontic therapy has to be carried out. Because there is loss of vertical dimension in cases of attrition, so orthodontic corrections to restore the vertical dimensions, increase the bite, has to be carried out. Now we'll see the other regressive alteration, that is the abrasion. It is also a commonly occurring tooth surface wear, but it is not physiologic as attrition is. Abrasion is the pathologic wearing away of tooth surface. It has been attributed to use of dentrifices previously. Nowadays the modern dentrifices are like soft in nature and they are not that harmful. But previously, when we see the history, abrasive dentrifices with very hard bristles were used. They used to cause more of loss of enamel and dentin surface. But considering today's history, even now when there is injudicious use of toothbrush, like when you carry out the horizontal toothbrushing method, it leads to damage of dentinal surface and cemental surface more commonly. More than the enamel, cementum is damaged here. So loss of cemental surface along with the dental surface is nothing but abrasion. Abrasion is more commonly seen in association with gingival recession cases. Yeah, and associated horizontal toothbrushing method or injudicious use of toothbrush. So because of the frictional force between the toothbrush, because of the indirect toothbrushing method, it leads to loss of the cemental surface. And few of the habitual habits of the patient, like habitual opening of the bobby pins, it leads to notching of the incisal edges of maxillary anterior teeth. Then there are few of the professions like the carpenter, the tailor, those who indulge in the habit of keeping something in their mouth like pins and all, they show this notching of the incisal surfaces or the wear of the tooth surfaces. That is nothing but the abrasion because of the frictional surface. And pipe smokers. So see, apart from the regular cigarette smoking and all, previously there used to be big pipes which patients used to smoke. There will be loss of tooth surface that conforms to the size of the pipe. So as the pipe, suppose it is like circular in shape, you can see tooth surface loss mostly restricted to the maxillary central incisors teeth. So as the shape of the pipe, such tooth surface loss may be seen. So here in the clinical picture, you can see the upper picture is showing the notching of the incisal edges, maybe because of some habitual tooth surface loss. Most commonly canine premolars in the gingival area, wherever there is gingival recession, tooth surface loss may be seen, and it is the abrasive tooth surface loss is in the form of a V shape or a wedge shape defect, and the lesion appears to be wider in diameter than in depth. When in the maxillary anterior teeth, just a notch or break of the incisal edges may be seen. So based on the etiology, you have to correct the habit. Like suppose the habitual opening of bobby pins is the cause for abrasive tooth surface loss, it has to be corrected, and aesthetic restorations have to be carried out, and proper tooth brushing method has to be taught to patient, so that you prevent recurrence of the disease once you treat the abrasive tooth surface loss by either the glass ionomer composite restorations or the glass ionomer restorations or the composite restorations. Now we'll see the other regressive change, that is the erosion. Erosion actually is the loss of tooth surface by any chemical process, by either by intake or by extrinsic sources, whatever be the cause, the loss of tooth structure is irreversible. Once the enamel surface has been lost, it cannot be replaced. So some chemical process is involved in tooth surface loss. So acidic foods, basically, if we take the extrinsic sources of erosion are the acidic foods, like the dietary food, whatever we take. Suppose consumption of soft drinks is common in children and adults, almost everyone. So these acidic beverages, they have high pH, so they leads to loss of the enamel surface. Then fruit juices like citrus fruit juices, they are acidic in nature. They are when consumed excessively, they lead to loss of tooth surface. And medications, few of the medications like especially vitamin C supplements, they are not taken orally directly. They are just chewed onto the oral surface. So whenever they are chewed, the contact between the tablet and the tooth surface, it leads to some amount of chemical change on the tooth surface. And few of the professions like wine tasters, they also notice erosion of the tooth surfaces. Erosion is usually seen on the buccal or cervical areas of the teeth. And the intrinsic sources are the exposure of oral cavity to fluids regurgitated from stomach, either because of some gastrointestinal disorders like peptic ulcers, gastrointestinal ulcers, or excessive vomiting associated with disorders like anorexia and bulimia. So whenever the regurgitated acid is exposed to the teeth surface, it has a very low pH, like about it has less than pH is less than 1, so it leads to erosion of the tooth surface. So here in the clinical picture, you can see there is loss of the enamel surface. Usually all of the buccal surfaces show this loss, tooth surface loss. So it's a very broad in nature. The tooth surface loss, it covers most of the tooth surface buccally, and because of the loss of enamel surface, there is increased incisal translucency and there is wear of occlusal surfaces, and exposure of dentinal tubules to oral fluid, it leads to hypersensitivity and pulp exposure. So treatment for abrasive tooth surface loss is identification of the etiology and treating accordingly. So suppose consumption of acidic beverages is the cause, so you have to restrict the acidic food intake or fluid intake, or medication, whichever is causing the tooth surface loss has to be stopped. And you have to instruct the patient that immediately after consumption of a soft drink, he should not brush his teeth, because whenever the oral cavity is exposed to such an acidic fluid and there is some chemical processing occurring on the surface of teeth, immediately when you brush the surface of teeth, then there are more chances of abrasion of the tooth surface. And if hypersensitivity is the problem, then composite restorations have to be carried out to restore the tooth surface loss and to reduce the sensitivity. You can increase the enamel surface hardness by topical applications of fluoride also. So that's with the abrasive tooth surface loss. Yeah, suppose the gastrointestinal disorders are the cause, then appropriate physician evaluation has to be carried out, and appropriate treatment for the gastrointestinal disorders to prevent the regurgitation of fluids has to be carried out. So that's with the erosive tooth surface loss. Now we'll see the other tooth surface regressive alteration, that is the abfraction. Abfraction is nothing but the loss of tooth surface occurring because of the flexional forces, whatever is occurring in the tooth. So whenever the tooth is subjected to some masticatory load, there is some amount of flexion occurring in the tooth because of the tensional and the compressional forces within the tooth surface. So these biomechanical loading forces result in flexure of the tooth surface. Ultimately, enamel is fractured from the surface of tooth. Yeah, this is abfraction are also seen on the most commonly on the cervical thirds of the root surface, or on the gingival third of the root surface, or the cervical third of the crown. So heavy occlusal forces are the main etiology behind the abfraction tooth surfaces. Abfraction is seen in the buccal and cervical areas of teeth basically. So it's a deep, narrow, V-shaped defect. As we know, with each bite, occlusal forces, they cause the teeth to flex. So whenever there is constant occlusal forces or heavy occlusal loading on the tooth surfaces, it leads to increased flexion and ultimately enamel fracture. So here, these pictures, these diagrams denote the abfraction causing tooth surface loss. It's just a wedge-shaped defect. It's more deeper than wider. Whereas the abrasive tooth or erosive tooth surface loss or the abrasive tooth surface loss, they were more wider. Here it is abfraction tooth surface loss. It is more deeper than wider. It's basically a saucer-shaped lesion. So identification of heavy occlusal forces is the main criteria. So once you identify the heavy occlusal forces, usage of bite planes or some amount of occlusal splints, they help to give relief to the teeth surfaces, relief for the fraction of tooth surfaces. So that's with the commonly encountered regressive alterations of teeth. Now we'll move to the mechanisms which are present in the dentin to prevent any disturbance to the tooth surface, like the dentinal sclerosis. Dentinal sclerosis is actually a physiologic change occurring within the tubules of dentin. They show increased deposition of calcium within the tubules. Thereby, they block off the dentinal tubules, preventing further invasion of microorganisms. So that's like a preventive method for progression of caries. So dentinal sclerosis is also known as a transparent dentin. So when is the calcification of dentinal tubules occurring? Whenever there is some form of caries to the tooth surface, whenever there is some form of trauma, or dentinal sclerosis is also a part of aging process. So as the individual advances in age, more and more calcification of dentinal tubules occur, leading to formation of this sclerotic dentin. So what is the source of calcium salts? From where are the calcium salts entering the dentinal tubules? It's nothing but, we know that odontoblastic processes, they have a fluid within them. So that fluid is the source of calcium salts for the dentinal tubules. So sclerotic dentin, actually it's advantageous to the tooth surface because it decreases the conductivity of odontoblastic processes, thereby decreased hypersensitivity, and it stops or arrests the carious process because it blocks of the microorganisms from entering more deeper towards the pulpal side. And presence of sclerotic dentin is indication of slow progression of caries. So that's with dentinal sclerosis. Dead tracks are nothing but whenever we take a ground section of teeth and examine in transmitted light, this zone, it appears as black. Just the deposition of dentinal tubules, it appears as black in transmitted light and white in reflected light. The difference between the exposure in the transmitted and reflected light, it is because of difference in the refractive indices of the tooth. These are nothing but tortuous deposition of the dentinal tubules in response to trauma. So the dead tracks is just an optical phenomena. Whenever odontoblastic process, whenever it loses the fluid and there's death of the odontoblastic processes, the dentinal tubules automatically become sealed off. So such, when examined in transmitted light, air appears to fill the tubules and it gives an appearance of black in nature, giving the name dead tracks. Secondary dentin is also a form of protective in nature. So dentin formed, this is the dentin formed in response to some abnormal stimulus after the completion of tooth. Slightly normal or abnormal stimulus leads to formation of this secondary dentin. Secondary dentin deposition is of two types. There is a primary secondary dentin deposition, there is a physiologic secondary dentin deposition, and the reparative secondary dentin deposition. So what is the difference between the primary dentin and secondary dentin? Primary dentin is formed before the completion of tooth, or during the tooth formation, the dentin deposited is known as the primary dentin. Whereas secondary dentin is the dentin which is formed after the tooth formation is complete. And secondary dentin shows irregular dentinal tubules which are tortuous or very few in number. And secondary dentin, whatever is deposited is very less mineralized, less calcium, phosphorus depositions are seen in cases of secondary dentin. So what is physiologic secondary dentin? Physiologic secondary dentin is the dentin deposited around the pulpal chamber, where this physiologic secondary dentin deposition occurs throughout the life of the person. It is deposited only around the pulpal chamber, surrounding the pulp chamber, and this physiologic secondary dentin deposition accounts for the reduction in sizes of pulpal chambers as age of the person advances. Reparative dentin is nothing but irregular secondary dentin formed in response to abnormal stimulus or trauma. So once the some stimulus is there or some form of trauma is there, secondary dentin deposition occurs and it seals the odontoblastic processes, thereby preventing the spread of the carious process or trauma, whatever. So these dentin, whatever is deposited, is showing of irregular nature, fewer dentinal tubules, and very less amount of calcium and phosphorus are deposited, showing less mineralized content here. You can differentiate between the primary dentin and secondary dentin histologically because it shows the presence of resting lines within the histologic section or the ground section, and fewer tubules which are tortuous in appearance. And if the secondary dentin, suppose during formation, if it entraps the odontoblastic processes, and increased deposition of osteoid occurs, and it's very similar to the deposition of bone. So the term osteodentin is applied whenever odontoblastic processes are entrapped during the formation of secondary dentin. So that's with the secondary dentin deposition. Both the secondary dentin deposition or the sclerotic dentin, both are just the normal mechanisms present within the tooth surfaces to prevent any harm occurring to the pulp. They are basically protective mechanisms to prevent pulp exposure. So what are the disturbances occurring in pulp? So pulp shows response to trauma in the form of calcification, either the formation of discrete pulp stones or diffuse calcifications. So pulp calcifications, basically they are of two types. There is a pulp stones, denticles, pulp nodules, or diffuse calcifications. Pulp stones are nothing but deposition of calcified masses in the pulp chamber of the tooth or the root canal. Mostly pulp stones or denticles are seen in the pulp chambers, whereas diffuse calcifications are seen in the root chamber. So pulp chamber, once the two denticle forms, they are seen, they may be attached either to the dentinal wall or they may be lying free in the pulp chamber. Based on their relation to the dentinal wall, they are divided as true or false pulp stones. Okay, true, false, and attached pulp stones. There is a difference between true and false denticles also, because based on their structure. True denticles are depositions of osteoid tissue in the pulp chamber, and the osteoid tissue, whatever is deposited, it shows similarity to the dentinal tubules. Whereas false denticles are depositions of osteoid which are like irregular in nature or which are concentric in nature and do not show any similarity or resemblance to the dentinal tubules. So the classification of pulp stones is based on structure and attachment to dentinal wall. So what are true denticles? As we have already seen that true denticles are nothing but localized masses of calcified tissue seen in the pulp chamber, and they resemble the dentin structure. False denticles are nothing but they are also seen in the pulp chamber. They are also ossified calcified tissues, but they do not have the tubular structure of dentin. Instead, they are arranged in concentric lamellar ring-like structures. They are formed around a central nidus. What central nidus, that is not known, but whatever the mass of tissue is there, it is arranged in concentric layers of tissue. So we can see the radiographic appearance of pulp stones. Clinically, you can just see a calcified tissue located in the pulp chamber. So not that clear radiograph, but you can obviously see that some in middle of pulp chamber, radiolucent pulp chamber, you have some calcified tissue there. So that's in the pulp chamber. Whatever pulp stones or denticles are seen, they are seen in the pulp chamber. Root, root surface area, root canals, they show diffuse calcification. This diffuse calcification, also known as calcific degeneration, it appears as irregular calcified deposits which are amorphous, which are homogeneous in nature, which are specifically seen as calcified deposits around the blood vessels. They parallel the direction of blood vessels. So these calcifications usually resemble the degeneration. So more common in the root canal. So diffuse calcification or the pulp stones, whatever they are present, they can be seen on the radiograph, and clinical implications are presence of pulp stones in the pulp chamber has been associated with neuralgia. So patient complaints of pain, severe sometimes or sometimes asymptomatic. So the presence of pulp stones, they pose problem in root canal therapy. So if root canal therapy is not possible, or it is extremely difficult for the patient to bear the neuralgic pain, the teeth has to be extracted. So other common regressive alteration is the resorption of teeth. As we all know, the roots of teeth resorb normally at the time of exfoliation of teeth. So this is seen more commonly in the deciduous teeth which resorb before they shed. Some form of resorption is also occurring in the permanent teeth due to variety of reasons. Like if the resorption begins either because of on the periodontal surfaces or the periapical surfaces because of the periapical inflammation, if resorption is occurring and all, it is known as external resorption. If the resorption is beginning just centrally in the tooth without any obvious cause, it is known as the internal resorption. There is also idiopathic resorption of tooth because it occurs without any specific cause. So external resorption of tooth is the tooth surface loss, which is seen because of variety of reasons like the periapical infection. Whenever caries process has begun in the tooth and it has approached the pulp, periapical infection has begun. Initially, we can see granuloma formation in the surrounding the roots of teeth. This granuloma formation, as we know, granuloma is highly vascular. It leads to stimulation of osteoclasts. So osteoclast, once stimulated, they leads to resorption of the periapical area and the resorption of the associated roots of teeth. And we also know that implantation or transplantation of teeth, whatever are carried, where are nothing but are comparable to bone grafts placed on the tooth surface. Because implanted tooth will be most of the times non-vital or endodontically treated tooth only. So there is no vascular supply between the implanted tooth and the jaw. So it acts as just a temporary scaffold of bone. So ultimately it has to resorb. So after resorption, what happens is the bony fusion occurs between the implanted tooth and the jawbone. It leads to ankylosis. But initial resorption is present. That is also a form of external resorption. Then we can see that presence of tumors or cysts has mostly shown either the resorption of teeth or the displacement of roots of teeth. So cysts causing root resorption is mostly because of pressure phenomena. So whenever the cyst enlarges because of the increased hydrostatic pressure, it ultimately leads to activation of osteoclasts and ultimately leads to root resorption. That's also a form of external resorption of roots and is pathologic. Internal resorption, it's the resorption which is beginning centrally within the tooth surface. It is also known by other names like odontoclastoma or internal resorption, internal granuloma, pink tooth of memory. Internal resorption is characterized by resorption which begins centrally within the tooth surface within the pulp chambers. So once the tooth surface is resorbed, it is replaced by the hyperplastic pulp tissue. So the hyperplastic pulp tissue gives the pink appearance to the crown. That is nothing but the pink tooth of memory. And the central resorption occurring in the tooth, it is basically occurring because of the inflammatory process. There is the inflammatory hyperplasia of the pulp tissue. So the first clinical sign, there are no evidences of periapical infection initially. The patient does not report any symptoms, and when you see the crown surface, you can see the pink hue or pink color appearance of the crown surface. That's because the area has been resorbed and it has been replaced by the pink pulpal tissue. There is the vascular tissue which is being seen through the enamel surface. So if the resorption occurs in the crown, you can just see in the oral cavity as pink appearance. If the resorption is beginning in the root, it is difficult to clinically evaluate such a internal resorption. Sometimes the root resorption, root shows internal resorption and extreme perforation, and after perforation, if you notice there is no other treatment apart from extraction. Okay, if you notice the resorption of the crown surface, then you can replace endodontic therapy has to be done, and you can replace it with a composite restoration. So because of the activation of odontoclast and resorption of the root surface or the crown surface, this internal resorption is also known as odontoclastoma. Radiographically, you can just see a round or ovoid radiolucent area on the surface of crown, and associated periapical infection is present invariably. And when you see the microscopic picture, you can see there is a resorption of the inner or purple surface of dentin along with the proliferation of pulp tissue, and numerous osteoclasts are seen, and associated hyperplasia of pulp is present. So chronic inflammatory cell infiltration with lymphocytes and plasma cells may be seen. So that's about the internal resorption. So we have seen the changes occurring in the enamel, the dentinal surface, the pulp surface, and how the roots are affected, how the cementum is affected. Hypercementosis is a regressive alteration. It is characterized by deposition of excessive amounts of cementum on the root surface. Hypercementosis is a non-neoplastic condition. There are a lot of etiological factors responsible for forming the deposition of the cementum. There is deposition of the secondary cementum. So hypercementosis involves the entire root surface. So the one common cause for deposition of cementum may be accelerated elongation of tooth. Whenever the opposing antagonist is extracted, the lower teeth, if the upper teeth is extracted, the lower teeth just shows elongation or extrusion of the tooth surface. So as we all know, the periodontal ligament surrounds the root surfaces, and in order to maintain that resiliency of the periodontal ligament, cementum is deposited on the root surface. That's a cause, extraction of the opposing tooth. It's a cause for hypercementosis in the tooth. Then inflammation or periapical inflammation occurring in the root surface of tooth. Whenever we know that periapical inflammation occurs, resorption occurs. Along with resorption, some amount of deposition of tooth surface occurs anyway. So here the resorption is occurring in the periapical area, and deposition of cementum, excessive cementum is occurring anywhere along the root surface, not just the periapical area. Resorption is occurring in the periapical area, whereas deposition is occurring in the along the root surface, anywhere at a distance from the root surface, at a distance from the periapical surface. And as we all know, whenever heavy occlusal forces are subjected to that on that surface of tooth, the tooth tends to repair it by formation of osteoclasts or osteoblasts are activated. Cementoblasts are activated. They leads to deposition of cementum on the root surface. And osteitis deformans or Page's disease is a generalized skeletal disease. It is characterized by excessive deposition of osteoid along with the generalized body. Tooth surface shows the excessive deposition of cementum on the root surface. So generalized hypercementosis of all the root surface of teeth, along with the complete disappearance of lamina dura is seen. So clinically, hypercementous tooth present no signs or symptoms, no hypersensitivity or no increase or decrease in tooth sensitivity, no sensitivity to percussion, no clinical features for this disease. Actually, hypercementosis is just discovered on radiographs as small outgrowths or spikes of cementum may be seen. Just the root surface, it shows the small outgrowth of the cementum on either the apex or anywhere along the root surface. So basically it's detected on radiograph. And when you see radiograph, you can see that the root surfaces appear to be rounded. Normally the apex has to be pointed little bit or conical like, but here there is rounding of root apex and apparent thickening or thickened roots, very bulky roots may be seen. So when you see microscopically, there is deposition of excessive amounts of cellular cementum, or the primary cementum is acellular, whereas here the secondary cementum or whatever new cementum is deposited, it's cellular in nature, and the cementum deposition occurs in concentric layers like. So that's with the hypercementous tooth. Hypercementous tooth pose no clinical problems apart from the fact that after extraction you may notice that the roots are big and sometimes it may pose little bit difficulty in extraction. That's it. And deposition, like we have seen the deposition of pulp or pulp stones or the calcified tissue deposits in the pulp chamber. Sometimes you notice calcifications in the cemental side or the periodontal ligament. So that those are nothing but the cementicles. They are small foci of calcified tissue which lie free in the periodontal ligament, either on the lateral side or the periapical root areas. So how the ossification occurs in the periodontal ligament area? So initially we know that epithelial rests of molasses are present. If calcification occur in the epithelial rest by deposition of osteoid tissue or calcium deposition, that leads to formation of this calcified tissue. So the whatever the calcification occurs, it occurs in the form of concentric layers like lamellated structure. So one etiology is the calcification of nests of epithelial cells, and sometimes what happens is cemental lining, whatever is present surrounding the periodontal ligament, it just breaks off from the surface. That cementum, whichever is torn from the root surface area, it is just seen as deposition in the periodontal area, and that's nothing but the cemental tears. So break of cementum from the root surface visible as small spicules, that's also a cause of cemental tears. And sometimes calcification occurs in the connective tissue between Sharpie's bundles. That's also giving appearance of cementicles. And calcification of thrombosed capillaries in the periodontal ligament occurs. That's all. Those are nothing but the cementicles. And cementicles are very, very small. They are not seen on radiograph. They are just 0.2 to 0.3 mm in diameter, and there are no clinical manifestations of presence of cementicles. They may be just seen histologically as ossified deposits in the periodontal ligament cells. So that's with the regressive alterations of teeth, both the hard tissues in the enamel, dentin, pulp, and cementum, whatever is affecting. So both the physiologic and pathologic processes together contribute to the regressive alterations of the teeth.